Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Again, I'm Jack West. I'm a medical oncologist at City of Hope Cancer Center in the Los Angeles area and founder and president of GRACE. Dr. Millie Das, Stanford University and the Palo Alto VA.
Yep.
And Dr. Matt Gubens at University of California, San Francisco, in San Francisco, obviously. Thanks a lot. We're going to be talking about the setting of stage 3 or locally advanced non-small cell lung cancer. And just by introduction, I would say that it's a common setting, that about 30%, somewhere in the range of a third of our patients with lung cancer present with stage 3 disease. And I think that one of the challenges, the complexities, is the range of what is called stage 3 that can include just a microscopically involved lymph node in one of the lymph nodes, in the middle of the chest between the lungs. It can involve multiple lymph nodes throughout the middle of the chest. They could be quite bulky, and sometimes it is appropriate to really consider surgery for some of these patients. But in the majority of patients with stage 3 disease, they are probably not well served by doing surgery once you have many lymph nodes involved or more bulky disease. So if you have a patient with multi-station, that is many lymph nodes involved, N2 disease, stage 3, you decide that this is not a patient well served by surgery. Do you order molecular tests for this? A setting like stage 4, we routinely do, but in stage 3, it's not clear whether we would use this information or whether you would order molecular testing. So if you have someone, say, with an adenocarcinoma, which is one that would have a reasonable chance of having a mutation, do you order it? And think how this might inform your management, or do you say, this is not a setting where that's standard, don't ask, don't tell, it's only going to complicate things. So what is your approach for a patient who would otherwise be a candidate for chemo and radiation followed by typically immune-based therapy? Matt?
Yeah, so I think that's a really important point, that in the academic setting, we kind of always want as much information as we can get. And so I think from our point of view, we're always getting it mostly to kind of triage patients for potential involvement in clinical trials. There's also an element of prognosis. We do know that even stage for stage, certain mutations might actually portend better outcomes. But I think another practical reason is, and we'll talk a lot about, we're treating these patients for cure. We hope that our chemo and radiation, plus or minus surgery, plus or minus immunotherapy, is going to cure the patient. But still a majority of these patients will progress. And sometimes it's nice to have this information in our back pocket so that if and when they do progress, we're not starting from scratch and starting that 4-week clock toward getting those data to get them started on treatment. So for all those reasons, we do tend to get it, but I fully acknowledge that generally I'm not going to use it in my treatment decisions for these patients.
Do you think it should be any kind of standard of care? I mean, what if a colleague out in the community asks you if they should be doing it? Do you say it's an option but not a standard, or do you recommend it?
That's probably how I would pitch it, as an option, not a standard. That's how I would pitch it.
That's exactly what I would say. I don't think it really informs our treatment decisions right now outside of a clinical trial. We did have the energy oncology trial open at Stanford, where patients with EGFR and ALK were randomized to receive either, targeted therapy, a lead in a 2 months targeted therapy followed by chemoradiation versus just going straight to chemoradiation. So of course, in that context, it was important to know whether a patient had EGFR or ALK, although I think that study has closed because it is tough to get that information, and it's not part of standard practice. And so it's not something I would generally do or recommend as standard practice. But again, in an academic setting, I think it's useful to have that information. From a practical standpoint, I've asked our pathologists to send molecular testing on any lung cancer specimen just as a reflexive testing. And so I do generally have that information, but do I act on it in these patients with stage 3 disease? No, generally not.
Do you have any concerns, whether in your practice or for people out in the community, that this testing costs money and maybe won't be covered by an insurer?
That's a good question. I think that's something to consider.
Yeah.
I think I'm a little bit naive when it comes to that, working in an academic and then also government, facilities. I don't think as much about that, but I think that brings up a great point, especially if it's not going to alter your management.
To cut to the chase, I would never tell a patient to spend $5,000 on these results.
Right.
We usually get it. It either gets forgiven or the university kind of eats the cost. But I completely agree that I wouldn't go out of my way to recommend it because it's not going to change practice in the short term.
So if you had a never smoker with an EGFR mutation that you identified, the key trial that we use to guide our treatment for stage 3 lung cancer, which is called Pacific, gave chemo and radiation and then followed that with up to a year of Imfinzi, durvalumab immunotherapy in patients who hadn't progressed. And there's a clear survival benefit. This has become our standard of care. But in a subset analysis looking at the various variables that seem to be associated with more or less benefit, the patients with an EGFR mutation did not seem to get a benefit. Mm-hmm. And in patients with stage 4 disease, the patients with an EGFR mutation often get pretty minimal benefit from immune therapy. Would that inform your decision? You both said that you generally wouldn't use molecular testing to guide decision making, but does this information about the subset of EGFR mutation positive patients lead you to feel that you'd be less enthused about recommending Imfinzi or even consider giving an EGFR inhibitor as consolidation in this setting? Millie?
Yeah, I think that does bring up a very good point. So I think it's a conversation that you have with your patients. And, especially when we're not seeing that benefit, and it's committing a patient to an additional year of therapy that otherwise they wouldn't necessarily need or be coming in for. So talking to them about this particular subset analysis, I think one of the things that also comes up in these EGFR patients is if they do recur or progress after chemoradiation and you're going to be offering them osimertinib or Tagrisso, there's some worry about the overlap of them having received durvalumab and osimertinib and the risk of pneumonitis in that setting. And I think that complicates things even more. Mm-hmm. So I probably wouldn't recommend the durvalumab as strongly in an EGFR patient if I have that information up front. Again, have a conversation with them about that. And I would also just bring up the concern for the risk of pneumonitis if we were to have to switch to osimertinib.
So to have a thorough discussion and then come out of that as a shared decision about whether to proceed.
Risks and benefits, exactly.
Matt, what's your approach here?
I think it's a tough issue and warrants a lot of discussion. We have to kind of take a step back and realize that there are only about, 44 or 45 patients with EGFR that were recognized on this trial. So we're talking about very small numbers. So I admit that to my patients, and I've had this conversation with a couple of patients who had EGFR mutations, and often these are very savvy patients anyway by their demographics. And I've shown them this slide that talks about how these patients did. With such a small patient population, it's hard to know what the real answer is. And the point estimate, meaning kind of if you have to put a number down, how much did they benefit, did slightly favor durvalumab or Imfinzi, but it just with huge, we call error bars, kind of a lot of variability that we don't really know the answer. Right. So the couple of patients I've talked about have chosen to do it, but I think all these points are well taken, that you're committing patients to a year of drugs that granted, it's easier for most patients than chemoradiation, but has real honest to goodness side effects. And one of my EGFR patients came off for autoimmune diabetes. She will be on insulin for the rest of her life for a treatment that we're not sure improved her overall survival benefit.
Right.
But on the other hand, you're also, this is the one, we are looking for cure here. And I think patients are looking for anything that might even marginally add to that cure rate. EGFR inhibitors don't cure, as far as we know, with the data we have. So it's a conversation, but I think it does speak to the fact that we need to be including EGFR in outpatients in these immunotherapy trials. A lot of the companies that run these trials exclude them. Study them
more systematically than just
with numbers.
Yes.
Exactly. And I think that's important.
You make the very good point that these are patients who could be cured without this. I mean, before we were using immunotherapy, people did get cured. It's not as common as we would like, but it's not astronomically low chances. It's maybe 1 in 5 at best, 1 in 4, but possible that the survival is better with immunotherapy. And I think because of that, in a high risk situation, it justifies kind of accepting some risk and going for the brass ring. But we do need to not be cavalier about the risks of bad interactions, like if we are going to be giving Tagrisso afterward if they progress. So these are tough questions.
And I will say for those patients, for generally on durvalumab, on Imfinzi, I will get imaging every 3 months, but especially for that EGFR patient, I sure want to find that progression. If it's going to happen early, I want to have a chance to wash out the durvalumab so that I'm even more kind of attentive to that patient and then their progress over that year of immunotherapy.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, and Takeda. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.